All right. Everybody ready? Yeah. So before we start, I would like to ask if should I ask now? Should I not ask now? No, it's okay. I'll ask this later. We'll do this a different time. But anyway, let's continue from where we stopped last week. We started talking on heart failure. Yeah, we started talking a little bit on heart failure. We talked a bit on the classification and different types of heart failure and ways to compensate. Yeah, we talked about Frank Starling's mechanism, and we also talked about a little bit on vasoconstriction. So what we're going to talk today is still on heart failure, and we are going to go in important details that we need to understand in order to be able to treat it correctly. And understanding the pathogenesis of heart failure will know you'll then be able to understand why certain drugs are being prescribed. And they are not just prescribed for because they are cardiovascular drugs, they are prescribed because they are they are directly affecting the pathogenesis of the disease itself, the progression of the disease itself. Anyway, we've talked last week how generally heart failure is divided into systolic and diastolic dysfunction. Yeah, we we also talked about different ways that we've been taught in school how to classify heart failure based on acute or chronic, based on like what we've talked this now, systolic and diastolic, backward, forward, low output, high output, and based on different classification of different associations, American Heart Association, New York Heart Association, KILIP, and in Russia, the Srajevska-Vasilenko classification. There's a lot of things to consider, and I would like to talk a little bit on the classification where we divide it into low output and high output heart failure. From the name itself, we understand output means something that goes out, right? And based on the definition of heart failure, which we talked about last week, we remember we said that heart failure is not a diagnosis, a disease on its own. It is a complication. Um, it's a complication to the main diagnosis. So you need to have something in front before writing acute heart failure or chronic heart failure, stage um, what degree and severity and stuff like that. So we talked about how it is actually a syndrome associated with structural functional abnormalities and with both systolic and slash or diastolic dysfunction associated with neurohormonal disbalance as well. But none in that definition talks about it being low output. Though from the name itself, heart failure, we understand that because the heart is failing. So technically, from the term itself, we understand that the heart is not pumping very well. So output should be low, right? From that term, from the name itself, which actually is the truth. Most of heart failure is considered as low output heart failure, mainly because there is a pumping failure. heart is like a pump, right? When there is a pumping failure, so it can be caused by a lot of things, be it from medication usage and medication. If you have too much, if you give the patient too much beta blockers, or you prescribe beta blockers without any consideration, or without considering contraindication, dosage, and all that, too much of beta blockers can be a problem. AV blocks can be a problem. Um, MI also can cause uh, problem as well. Wait, so sorry, give me a sec, okay? Uh, right. So pumping problem, yeah. It can be it can range from many different etiology, including an overdosage, even overdosage of any negative inotropes. It can be an excess in preload, excess preload. We talked about these terms, yeah. Preload and afterload. When there's an excess of preload, there's too much blood, uh, that can indicate pumping problem, be it in pregnancy, and especially when it is decompensated, the heart cannot compensate anymore, so there's excessive preload. And when there is chronic excessive afterload as well, in when there is, everybody remember, right, what is afterload? It means the amount of energy, or the degree of resistance the heart has to go up against. And when there's too much of that, that can be a problem too. For example, in aortic stenosis, in hypertension, that falls under low output heart failure as well. How about high output heart failure? It is high output heart failure is a bit rare, but it can still happen. So what does that mean, high output? It means that the heart is pumping normally. The problem is not in the heart, but the problem is because there's an excessive need. There's an excessive need. Demand is extremely high, that the heart has to pump more. And but the heart cannot um, meet up with that demand. So as to speak, we are referring this as high output heart failure. For example, anemic patients, pregnant patients, patients with hypothyroidism, when there's an external need for it. Hypothyroidism, it means the metabolism is very high. There's a need for more perfusion, right? So yeah, so these are the cases where high output heart failure can happen. So moving on, we've talked also about ways that the body compensates, and when it's too much, right? So when the heart starts failing, and yeah, basically when the heart starts failing, of course the body will try to accommodate. Initially, the body will start to accommodate. So what are the changes that the body would bring forth? Number one, in the heart, the end diastolic volume will increase. End diastolic volume will increase. It means that there is a lot of blood. End of diastole, right? Diastole is the relaxation of the ventricles. When it's too relaxed, when it's relaxed, and the end at the end of diastole, there's a lot of blood. So that is one of the way for the body to compensate. Second is through the cardiomyocytes. Through the cardiomyocytes, of course, the heart will dilate. Will try to dilate, and will try to uh, increase the size of the walls, which can cause hypertrophy. This is one of the ways for the heart to compensate too. This is the heart trying to compensate. Neurologically, neuronal compensation includes the increase in mimetic activity of the heart, sympathetic activity, adrenergic activity of the heart will increase. The body will try to, pump, try to exert more contraction because the heart is now not contracting well, so the body will try to release more epinephrine or your catecholamines basically to help to pump the heart. And because there is an increase in sympathetic activity of the heart, of course, when we talk about vagal activity, the vagal nerve, right? The vagal nerve does not belong to the activation of vagal nerve leads to a result that is not that is opposite to the activation of sympathetic nervous system. So it means that the when you activate vagal nerve, your heart will be more relaxed. Your heart rate will decrease. It basically distresses you. That's the function of vagal activity. However, in heart failure, the vagal activity will decrease. Logically, right? When your sympathetic nervous system is activated, your vagal activity will decrease. And the third way that the body tries to compensate is through your hormonal way of compensation. That is the activation of your angiotensin, renin, angiotensin, aldosterone system. Your body will release more renin to convert your angiotensin nogen to angiotensin nogen to angiotensin 2, causing vasoconstriction. Other types of hormones includes vasopressin, your brain natriuretic peptides, your natriuretic peptides, catecholamines that I already talked about just now too. I'll talk more on your natriuretic peptides a little bit later. So these are ways for the body these are the ways that the body tries to compensate to whatever it is that's failing in the heart. Your neurohormonal system. These are the two main ones that we need to understand. And from these two main ones, that is when your treatment comes into the picture. It affects both of this. So understanding this is important. Now, that is compensation. When the body, as any organism, the body tries to compensate, it will reach to a point where it's too much already. It's too much already, then the body will, of course, decompensate, right? So when the body decompensates, what happens is that you'll see a decrease in stroke volume. So what is stroke volume? Stroke volume is the amount of blood that the heart is able to pump out, right? So there's now not enough blood pumping out. So how is stroke volume derived? So it is N diastolic volume minus N systolic volume. That is your stroke volume. Okay, so decrease in stroke volume and also decrease in cardiac output. That is when it decompensates. Now it's showing signs of decompensation. Next point next sign that reflects decompensation will be decrease in ejection fraction. We'll talk about ejection fraction later on. Ejection fraction, it means that the heart is no longer ejecting very well. and I'll talk a little bit later about how currently they have classified heart failure based on the ejection fraction. Okay, so from this so far, uh, everybody understand? Yeah. Okay, I want to show you something that I would call model of a broken heart. Haha. But USMLE calls it model of a failing heart. Okay, everybody can see this, yeah? I hope everybody can see this. I couldn't find a better picture anyway, and this I think I feel that this is the best picture that I could find. And anyway, still on pathogenesis. As I talk about pathogenesis, I want you to look at this picture. We've covered a little bit already, and yeah. So look at this picture, yeah. So you see in the middle it says decrease in CO. By the way, CO does not stand for carbon monoxide. CO stands for cardiac output, okay? Not carbon monoxide. And that is the starting point. It says here, see the starting point. So as cardiac output decreases, we talked about two main systems, yeah, just now. First will be your neurohormonal system. Second will be your um, sympato sympatoadrenergic system, yeah, your sympatoadrenergic system. So your neurohormonal mechanism of heart failure, we talked about the renin-angiotensin aldosterone system. Let's see where it is here. Here, see renin-angiotensin aldosterone system. So what it does is that your angiotensinogen 2 will be increased too. Your renin, we talked just now, your aldosterone will increase. So what does this do? What effect does this cause? There are two main effects of increase of all of these hormones, renin and renin, angiotensin 2, and aldosterone. So what it does is are two things. First, your tissue effects. Second will be your plasma effect. So first, your plasma effect that will happen is that it will increase your sodium retention. Increase in sodium retention. See here, increase in sodium retention. That means that there is hyperkalemia. Yeah, hyperkalemia. Sorry, hypernatremia, not kalemia. Remember this, hypernatremia from renin-angiotensin aldosterone system, okay? And also there is decrease. There is also retention of water, sodium, and also water retention. That's plasma effect. Second, tissue effect. As you already know, angiotensin 2 is a very one of the most potent vasoconstrictors. Yeah, so it will cause vasoconstriction. See, vasoconstriction, which is also angiotensin 2, and your sympathetic nervous activity, which we're going to talk about later. Second will cause your left ventricular hypertrophy. That's still under tissue effects. Third is glomerular fibrosis. Fourth, vessel fibrosis. Vessel fibrosis. And lastly, your myocardial fibrosis. Tissue effects, vasoconstriction, left ventricular hypertrophy, the fibrosis of three things: glomerular fibrosis, vessel fibrosis, and your myocardial fibrosis. This is under tissue effect of activation of your RAS system. And all of this, you'll see patient with, that is why you see patient with edema. Even both edema, both acute and chronic heart failure. Acute heart failure, of course, you'll see pulmonary edema, right? That's the first thing that will happen in acute heart failure. Whereas in chronic heart failure, you see a pedal edema, your edema on your extremities, and also your diffuse edemas, which are your anasarca. All right, clear so far, yeah? So next will be your sympathoadrenergic system. Your sympathoadrenergic system is activated as a response to the decrease of your heart contractility, because your heart is failing, right? So it will try to compensate. That is why the system, there is an increase of sympathetic activity. So what it does is that it helps to increase your heart rate, see tachycardia, your vasoconstriction as well, and also because of because now there is an increase in contractility, there is also the strength of your contractility will increase too. Remember, your increase in contractility does not mean that the strength is also increased. Remember, inotropic, chromotropic, and chromotropic, right? They are all different. So, right. But this is when it is compensated. When it's not compensated anymore, this whole system falls. This entire system falls. It cannot adapt to it anymore. And you'll see venous congestion in your venous system. You'll still see increase in your heart rate, but it cannot meet up with the demand, with the increase in oxygen demand. And because of this, there is a very high risk for arrhythmias, especially fatal arrhythmias, which are your ventricular fibrillation and your VTach, your ventricular tachycardia. Okay, so that's clear, yeah? Any questions so far? No? All right. Understanding this, it means that we need to also know how to diagnose a patient when you suspect that the patient's heart is failing. When you suspect the patient's heart is failing. So, before going to diagnosis, I would like to show. Something. I scanned this. You can find this anywhere, even in lecture material and stuff like that. But I think this is just nice, and I think this has a little bit more than the lecture material from Dimitri. So I want to talk a little bit on Framingham criteria for congestive heart failure. So you see that there are two parts: your major criteria and minor criteria. And diagnosis of your congestive heart failure is at least 2 major criteria or 1 major criteria with 2 minor criteria. And you see all of this, we know that all of them are signs of heart failure, but we might not know which ones are major and which ones are minor. So you look up on your Framingham's criteria to know which one is major, which one is criteria, to which one is minor, to be sure that what you're looking at is actually your congestive heart failure. Okay. All right. Now, now that everybody understands the pathogenesis of, of heart failure, I would like to talk about a few chemicals, a few hormones actually, and some important things when it comes to diagnosis. So I don't know why this was not emphasized on throughout my study experience, but when I look up on different guidelines, textbooks, and well, different materials, this shows up very frequently, and even it even it even is coupled with the gold standard for diagnosis of heart failure, and that is your echocardiography. So I want to talk about natriuretic peptides. Maybe you've heard about this before, maybe you've not heard about this before, it's okay. So your natriuretic peptides, there are 2 major natriuretic peptides that we can measure when it comes to heart failure. That is your atrial natriuretic peptide and your B natriuretic peptides. So let me tell you a very short story of both of them. So these are hormones, by the way. These are hormones produced by the heart in response to straining of the heart, or when there is a volume overload of the heart. So both ANP, atrial natriuretic peptides, and B natriuretic peptides, they are released. Now from the name itself, atrial natriuretic peptide, it means that the atriums produce them. So understanding that means that your B natriuretic peptides are produced by the ventricles, yeah? But why is it not V natriuretic peptides? So from the name itself, it's obvious that A is atrial, and what they did before is that they found out that ANP, they injected ANP, the hormone ANP, into rats, and they noticed that the rats pee more. The rats pee more, and so they discovered that maybe this has diuretic effect. So why is B called BNP, brain natriuretic peptide, and not VNP? It's because they discovered that this hormone is actually firstly detected in pig's brain. B actually stands for brain. And they discovered that the ventricles produce similar hormones, the ventricles, instead of the brain from pigs. In humans, the ventricles of the heart produce them. So from the name itself, well, I've already said that they've discovered that they injected these hormones into rats, and they noticed that the rats pee more. In other words, it has diuretic effects. There are also vasodilators. They are not drugs, they're hormones, okay? They have vasodilative effects. The first vasodilative effect, second diuretic effect. Third, from the name itself, natriuretic peptides. Peptides are proteins, right? Natriuretic. Natri means sodium, right? Uretic refers to urine, right? So that means that somehow, sodium is in urine, right? So they also discovered the ANP and BNP. They have natriuretic effects. So what does that mean? That means that it that they inhibit sodium reabsorption. Reabsorption, not absorption. Reabsorption. It means, you know, in the nephron, there's loop of Henle, this and stuff like that, right? And sodium gets reabsorbed, but your ANP and BNP prevents or rather inhibits the reabsorption of sodium. So now sodium is in the urine. Okay, so sodium is in the urine, so it has natriuretic effect, ergo the name. It also inhibits your sympathetic nervous system and your renin, angiotensin, aldosterone system as well. In other words, understanding all of this, it is actually a form of compensation, a form of compensation, trying to neutralize, trying to neutralize what the body is trying to compensate, trying to protect the body. You know, the sympathetic nervous system causes vasoconstriction, but because there's volume overload, your ANP and BNP, both of them produce gets pro both of them gets produced, and instead of constricting the vessel, it dilates the vessel, right? Dilates the vessel. Now, second, diuretic. It has diuretic effects, right? And we understand the activation of renin, angiotensin, aldosterone system causes sodium and water retention, right? And patient is not peeing, it's not excreting any fluid. And your natriuretic peptides is a diuretic, is trying to compensate that, trying to fight that. Both fluid overload and your sodium overload as well in your body. That is what the body is trying to do. So understanding this, it is actually these two peptides, these two natriuretic peptides, they are still poorly studied, and um, however poorly studied as they are still one of the important criteria, important markers when it comes to heart failure. When you see an increase in your ANP and BNP, it means it is an indication that there is some form of volume overload in the heart. That's all. Some form of volume overload in the heart. So yeah, that's your natriuretic peptides. Other I wouldn't call them markers, but other chemicals that you can um, detect would be your vasopressin, which is under your sympathetic nervous system too, increasing vasopressin, like we talked about earlier on, and endothelin. They are both vasoconstrictors. So increase of these two is also an indication of heart failure. Okay, so any questions so far before we move on? No? All right. if there are no questions, let's see if I missed out on anything. Okay, so let's go back to the two main groups of heart failure, which are your systolic form and diastolic form, right? So from the name itself, diastolic, it means that there'll be a problem or some form of abnormalities in the way that the heart relaxes, not just specifically the relaxation of the ventricles. It can be due to multiple causes. It can be due to myocardial dystrophy, your hormonal disbalance, your thyrotoxicosis, your diabetes mellitus, especially when it's decompensated, and even to a point of genetics, genetic predisposition, which means which I would refer them to the cardiomyopathy part of our CVS diseases, which are your congenital cardiomyopathies. For example, your congenital um, dilated cardiomyopathy, and even your hypertrophic cardiomyopathy can cause diastolic problems. But cardiomyopathy can actually cause both systolic and diastolic disbalance or problem. So yeah. Next will be a systolic problem. It means there are problems with the way that the heart contracts and instead of relaxes. This is more prominent in diseases in post-infarctive cardiosclerosis, one of the complication of your MI. Post-infarctive cardiosclerosis, the heart has a lot of connective tissues already, a lot of scars and all that, so it does not really contract very well anymore. Next would be your post-infective cardiosclerosis, your myocarditis, infective endocarditis, and so many others. Infection can also cause scarring or increase of fibrosis scarring of your heart. So those are the two main ones, yeah? Now, let's talk about ejection fraction. Now, ejection fraction, as we already said earlier on, the gold standard for heart failure is your echocardiography. And your echo, what it does is that it measures your ejection fraction. Your normal ejection fraction should be about 50 to 70, 75. That's normal. Or 60, 55 to 75, around there. The higher the better, of course. So yeah, understanding that the heart failure is divided into systolic and diastolic when it comes to ejection fraction, it means that whatever it is that the what's it the results that the ejection fraction reflects will determine whether it is a systolic problem or diastolic problem. So understanding, bear in mind that whatever reading that you get from ejection fraction, it gives you a picture of whether it's systolic or diastolic problem. And why is this important? Is because treatment for systolic heart failure due to systolic dysfunction, and heart failure due to diastolic dysfunction are different. They're different. So there are different types of heart failure, that classification based on ejection fraction. First is your congestive heart failure with preserved left ventricular ejection fraction. First form, CHF with preserved LVEF. And what is preserved? It is more than 50% of ejection fraction. That's the first form. Understanding that your ejection fraction is normal. You see, ejection means that it reflects the contraction of the heart, right? So it means it reflects more of the systolic problem of the heart rather than diastolic, because something is being ejected, right? So if you see that the ejection fraction is preserved or normal, it does not mean that the patient does not have heart failure. You still see clinical symptoms of heart failure. So what does that mean? It means that it is a diastolic problem, not a systolic problem. When you see that your ejection fraction is preserved, it's a diastolic problem. Okay. Second form is your CHF, your congestive heart failure, with mid-range left ventricular ejection fraction, your LVEF, mid-range, between 40 to 49. So where does this fall under, systolic or diastolic? Truthfully, it can fall either one of them, because it's borderline between too low and borderline between too high. So it is both, the patient is a candidate for both systolic and diastolic problem, but it's more of a diastolic problem, but it really depends on the condition of the patient. The third form is congestive heart failure with reduced left ventricular ejection fraction, reduced. That is less than 40%, or in some guidelines, some books says less than 35. USMLE is less than 40. So this decrease of ejection fraction means that the problem is a systolic problem, right? It means the heart is not ejecting out anymore and is failing to eject enough blood out. So what does this entail? It means understanding the ejection fraction helps us to understand is systolic or diastolic, and helps us to estimate prognosis of the patient as well. And the next point that I would like to emphasize is that all the drugs that we're going to talk about later, the treatment and all that, it is only helpful in systolic heart failure, systolic problem of the heart. Systolic problem of the heart. It helps symptomatically, and it helps in terms of prognosis of the patient. It means that there is actually proven reduction of mortality for patient with systolic dysfunction. However, unfortunately, for diastolic problem, there is no solid treatment for diastolic heart problems. It means that when you see a patient with anasarca and stuff like that, and you see that the patient obviously meets the criteria for heart problem, like we talked about just now, right? Your Framingham's criteria with 2 major or 1 major and 2 minor. Although it checks the box, but ejection fraction is normal, diastolic dysfunction, unfortunately there's no treatment. So what we can do is just symptomatic treatment. Okay, everybody understand that? Clear so far? No questions so far? Okay. Oh, if no questions so far, let's move on to treatment of cardiac failure. Of cardiac failure. We are going to divide. This is the fun part of today's topic: how to treat the patient. Right? We're going to divide our treatment into two. One for prognosis, the other one for symptomatic treatment. Knowing that there are separating both of them, I think that it's important because you know that the treatment that we're going to give will only help for systolic dysfunction, systolic form of heart failure. And if it's diastolic, we'll just give symptomatic treatment and not your treatment for prognosis. So let's start with the first one. Um, the treatment that will reflect more on improvement of prognosis. So first step of treatment of heart failure, the first line, in other words, first line is to give ACE inhibitors. You give them in patients with the third form of heart failure, that is reduced heart failure, that is less than 40 or 35. You give ACE inhibitors. Now, from previous classes, we understand that we can't always give any ACE inhibitors, right? Some ACE inhibitors are more preferable, and some ACE inhibitors are not very much preferable. Same as calcium channel blockers. Your dihydropyridines, your amlodipine, nifedipine, your dipines, and your non-dihydropyridines, your verapamil, diltiazem. Which one will be better? Even under the same pharmacological group, we still need to be thoughtful about it. We still need to consider everything before actually giving the drug. However, for congestive heart failure, luckily, any ACE inhibitors would do. Any ACE inhibitors would do, because it has a class effect. Any of the ACE inhibitors, they have been proven to reduce mortality by, if I'm not mistaken, by 25%. If I'm not mistaken, I don't remember. I need to open the guideline again. So it means you can give the cheapest ACE inhibitors, your captopril, your enarapril, and it's fine. If you want it to be good, of course you give the latest ACE inhibitors, your lisinopril and your ramipril, the latest ones. Of course, the latest, the better, right? So what's the rule for giving your ACE inhibitors is just give whatever you can give once a day. Once a day. It means that even if you really want to consider which one to give, it would be good to give long-acting ACE inhibitors, which are your lisinopril, ramipril. If you give short-acting, like your captopril, it means that the patient will have to take more. Of course, it will be good for the patient to take less, right? So, however, we understand that ACE inhibitors has what effects? Anybody? Your negative inotropic effect, right? And you also give ACE inhibitors for hypertensive patients too, right? When we talked about hypertension last week, remember? Our first line is your ACE inhibitors, your ARB, plus your CCB, plus diuretics, the first line, right? So it means that it has hypotensive effect. It will reduce your BP. But understand that patients with heart failure they don't come in with increased BP. Of course, at first maybe initially maybe they have high BP, but as it decompensates, the patient might have hypotension instead. So this is the art of your prescription of ACE inhibitors. It means that you cannot give full dosage first. It means you have to give small dosage first. So whatever ACE inhibitors that you give, find out the full dosage based on your own country, your own hospital. Find out the full dosage. You start off with a quarter, 1/4 of your target dose. You start with giving that first, because your BP, like I said just now, your BP will be low. If you give full dose, the patient will be hypotensive and the patient will collapse. Then it will be a problem. So as BP normalizes, it increases, you can slowly titrate, increase the dosage until the optimum dose. How often can you up titrate it? You can up titrate every 1 to 2 months. You give a small dose, then you check, ask the patient to come back, check if anything is okay. If everything is okay, BP normalizes, up titrate. Like how we talked in our previous classes, again, your ACE inhibitors, you don't give it together with your ARB, your angiotensin receptor blockers. Technically, again, it has been proven that your ACE inhibitors are more efficient compared to your ARB. However, your ARB is better tolerated than your ACE inhibitors. Mainly because your ACE inhibitors, one of the side effects, like we talked before, is your drive cough and your pedal edema. Patient already has pedal edema because of heart failure. You're giving more pedal edema too. So yeah. However, there are a few things that we need to consider too. We don't give ACE inhibitors or ARB in all patients with heart failure. There are contraindications as well. And we also understand that heart failure is a syndrome, right? Anything can cause heart failure, like we already talked about earlier on. Even pregnancy. So what are the contraindication of your RAS blockers, your ARB and ACE inhibitors? Number one is your pregnancy. Number two is hypotensive patients. Number three is patients with double-sided renal stenosis. Your renal arteries are stenosed, especially when it's double-sided, both bilateral renal artery stenosis. Next is hypercalcemia. And lastly, your hypercreatinemia. It means if the patient has chronic kidney diseases or kidney failure, you don't give ACE inhibitors. Now, you might think, you might have maybe considered, maybe this crosses your mind, that if ACE inhibitors are less tolerated than your ARB, and we are concerned, or we are not really concerned. Dry cough is not a serious thing, right? Not a very serious thing, but it can bug a patient. and that is one of the main side effects of ACE inhibitors. You might think that, okay, if we want a good efficient treatment, and if we still stubbornly want to still use ACE inhibitors and not change to ARB, because normally when it's not tolerated we just change to ARB, you might think that, oh, maybe we should give some antitussive medication, for the cough, so that the patient does not cough. Logically, there's logic in that thought, right? There's actually, I don't know, it can probably help, but you need to understand that most antitussive drugs, they are central acting. They're central acting drug, because you have your cough centers in your brain, and it is affecting that particular center in the brain. So because it is central acting, there's a risk of aggravating your hypotension, and it is especially dangerous for the patient who are decompensating. So as much as we think it might help with the cough, it's actually not rational to use antitussive to combat your dry cough. Again, in the end of the day, the wisest choice would be to switch to your ARB, your sartans, right? So understand, yeah, that is ACE inhibitors. Second will be your beta blockers. Again, you might think, beta blockers, they are negative ionotropes, right? In patient, of course, most often they not come in with heart failure or in cardiogenic shock, even cardiogenic shock where the patient is already decompensating, patient is bradycardic and stuff. So why you want to give beta blockers? It won't make the situation bad. But the thing is that we still actually need to give beta blockers for congestive heart failure, but we have to give it correctly. If you give it wrongly, most of the time a lot of doctors give it wrongly as well. Patients will die because of wrong prescription of beta blockers. So what do I mean by correct prescription of beta blockers? Correct prescription. Number one is to use the most cardiac selective beta blockers. You don't give your normal propanolol, your labetalol, or those lolols. And the most cardioselective beta blockers will be your nebivolol, 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 and your bisoprolol, Bisoprolol. These are your most cardioselective beta blockers. You can also give metoprolol succinate, not just metoprolol. Metoprolol itself is not very cardioselective, but metoprolol succinate, they're they are cardioselective, and they're also long acting. So yeah, you can use metoprolol succinate, but better to use your nebivolol and your bisoprolol. Next, again, just like your ACE inhibitors, you have to give it at a low dosage, a very low dosage. ACE inhibitors, you give a quarter but your beta blockers, you give 1/8, an eighth of your full dosage, an eighth. So you understand, you see, we have to give ACE inhibitors plus beta blocker. They both have hypotensive effects, so you cannot give full dose. When the BP normalizes, then you can up titrate, of course. Up titrate. The same way how you up titrate your ACE inhibitors, you can up titrate your beta blockers every 1 or 2 months. Okay. Next, it was proven that beta blockers, it is only effective in compensative stage of heart failure. Only compensative. Because it is proven that in compensative stage of heart failure, it reduces your mortality by another 25%. Another 25%. So these are the principles of beta blocker prescription.
Decompensation or compensation?
Compensation.
Okay.
Use in compensation. So these are the main principles of beta blocker prescription. Number one, most selective beta blocker, your bisoprolol and nebivolol. Second, give in low dosage. Third, use only at compensation stage. Then you'll be fine. Okay. Now, you might think that instead of giving beta blockers and ACE inhibitors, and we see that the patient is bradycardic already, you might need to increase your catecholamines. You might want to give your sympathomimetics, your epinephrine, dobutamine, dopamine, to increase the heart contraction, because the patient is decompensating. Patients who have fainted, syncope patients. So you can consider giving your sympathomimetic to help the patient to increase the BP and also heart rate, especially in cardiogenic shock. So you can give your epinephrine and your dobutamine or dopamine, preferably giving dobutamine, because dobutamine is beta selective. Understanding that it's beta selective, it affects more of beta 2 selective actually. It affects the heart better than other parts of the body. Okay. Yeah.
Meaning, like, up to now, the fluid is not allowed, right, to be given to the patient, like IV.
Yeah.
The normal saline and.
Yes.
And what to do in case of the shock?
So in case of shock, so you can give instead of giving infusion, instead of giving IV infusion, you can give oral rehydrating salts or POS. It is less aggressive compared to IV.
By putting in the NG tube?
No, they're like small packets. You put it into water, then you drink.
Okay, like in case of shock, a patient is not unconscious or something. What can we do?
You give your epinephrine, dobutamine, and you give that first. You normalize the BP and your heart rate first. The electrolyte dysfunction, that is secondary. So you need to make sure the circulation is intact. Then as it normalizes, you then see what's next. Do you think if you see that the patient has severe pulmonary edema, then you treat pulmonary edema with diuretics first. Drain out all the blood first. Drain out all the fluid first, not blood. Then you see your electrolyte. Of course, step by step. Of course, there's a risk of electrolyte dysfunction, and especially when we understand when there is electrolyte dysfunction, it will also affect the heart. High risk for arrhythmia as well. So we have to really monitor everything. If we give too much diuretics and we see that there's more electrolyte dysfunction, then you can start giving specific electrolytes. Like if you see that your potassium is reduced, then you give potassium. Or your sodium is increased, so it means that if sodium is increased, you can still continue with your diuretics, no problem, because that's the purpose of diuretic, to get rid of your sodium and your water too.
Okay, thank you.
All right, those are the first line, your ACE inhibitors and your beta blockers. Second line. When your first line is not effective and you see that the patient is in functional class 2, 3, 4 of heart failure, what you can give are it's called MRA, mineral corticoid receptor antagonist. Mineralocorticoid receptor antagonist, or your aldosterone receptor blockers, the same thing. It blocks the receptors to aldosterone, because you see your renin, angiotensin, aldosterone system is activated, right? Increase in aldosterone. So what are they? They are your spironolactone and your eplerenone. Eplerenone, let me type it out. E-P-L-E. Spironolactone, I trust everybody knows spironolactone. Okay, everybody also need to know that spironolactone is also a form of diuretic, right? It's actually a diuretic, a potassium sparing diuretic. But eplerenone is not a diuretic. So we can start with giving spironolactone as a diuretic and also as an aldosterone receptor blocker. 2-in-1 effect. But the thing about giving spironolactone is that there's a risk for gynecomastia in males. So because there's a risk for that, that is why the eplerenone is there. So if there's a risk for gynecomastia, you see that there's some form of hormonal disbalance, then you don't give spironolactone, you give eplerenone. Okay, next is ivabradine. IVA bradine, B-R-A-D-I-N-E. It is indicated only in when the heart rate is above 70 and in sinus rhythm. Non-sinus, don't give. It means that if the patient has VFib or AFib or VTach, don't give ivabradine, even though heart rate is above 70. It was shown that your mineralocorticoid receptor blockers, your aldosterone receptor blockers, plus your and your ivabradine, they reduce mortality by 20 to 25% as well. They can actually be given together with your step 1 drugs, with caution, of course, as in addition to your step 1. Next drug, still under step number 2. This is a new drug. I only got to know about this drug earlier this year. Yes, earlier this year during the Therapy Olympiad this year. And also the drug itself is new to it. I think it came out last year, end of last year or something. And it's been placed in the guideline already too, so it's official. They are called ARNI, ARNI, angiotensin receptor blockers, and your nepirizine inhibitors, NEPYRISINE, nepirizine inhibitors, ARNI. So from the name itself, angiotensin receptor, so it means your sartan, right? And your nepirizine inhibitor. It's actually a combination of 2 drugs. The drug is called valsartan plus sacubitril. Valsartan combination of these 2. It helps to protect the blood vessels, and they discovered that sacubitril, it reduces mortality by 48 to 50%, close to half mortality. They also discovered that a combination of ACE inhibitors with sacubitril is not actually pharmacologically compatible. So that is why they use ARB plus sacubitril.
Norman,
Mm.
did you send the name to the chat?
Oh, I sent it to Tiopo instead. Sorry. Let me send it again. Okay, I send it to everybody. Okay. Where was I? All right. They discovered that ACE inhibitors plus sacubitril was not pharmacologically compatible. So the most logical move is to switch from ACE inhibitors to ARB, and they discovered that valsartan and ARB plus sacubitril is compatible and effective. So they form a ARNI, your angiotensin receptor, plus your nepirizine inhibitors. Okay, clear so far? Those are step 1, step 2. And this is for prognosis, improves your mortality. Next will be your symptomatic drugs. Step 3 now, symptomatic drugs will be diuretics, giving diuretics. There are different types of diuretics. I actually want to talk a lot on diuretics, but I don't think we have time for that today. We need to finish soon. Diuretics, we give diuretics because of the edema, right? And also we can also use it for prophylaxis, but depending on the severity, depending on the indication as well, as how severe is the congestion in the lungs, and also maybe on the legs, on the greater circulation. Greater circulation. So again, diuretics you have to give with caution too. You can't just simply throw whatever diuretics you want to throw. The first diuretics you can give will be your thiazides. Why you start with thiazides? Because it's not very aggressive. It has moderate action. If you give too much, the patient might go to the toilet a lot and might might be can dehydrate the patient, because this giving diuretics, in other words, is also called as dehydration therapy. So you start with thiazides, your chlorothiazides, hydrochlorothiazides, and just name whatever thiazides you want to give. So your first thiazide, first diuretic is thiazide. Second, if you see that it's not effective, you can give your loop diuretics. Understand that loop diuretic, it means that it affects the loop of Henle, right? On your nephron. Your loop diuretics, but you give in small dosage. It is now it starts to become more aggressive now. Your diuretics. So loop diuretics are actually more aggressive. So what loop diuretics you can give? Your furosemide or torsemide. Preferably giving torsemide, because it was discovered that it is more effective than furosemide, and it also, the duration of action is actually longer, 24 hours, as compared to furosemide that is 8 hours. So the patient does not have to take a lot of drugs. And you give in small dosage, not full dose. If you see it is not effective, then it means that your third step is to up titrate your loop diuretics. You give higher dosage of your loop diuretics. If it's still not effective, you give your loop diuretics plus your potassium sparing diuretics, your spironolactone. Choose any loop diuretics you want plus potassium sparing diuretics, which is usually your spironolactone. Understand that spironolactone is also your MRA, right? Now, if that still does not work, you give triple therapy, your loop diuretics, your thiazide, plus your potassium sparing diuretic 3. If that still does not work, you give 4. Loop diuretic, thiazides, potassium sparing, and your carbonic anhydrase inhibitors, which are your acetozolate. These are your carbonic anhydrase inhibitors. Well, you can read up on diuretics, or we can talk about it next week. All right. So last but not least, if it still does not work, your step 4 is to implant device on your heart. That's giving your cardiac resynchronization therapy, giving a pacemaker, or your implantable cardiovert defibrillator. Your CRT, or your cardiac resynchronization therapy, or your ICD, your implantable cardioverter defibrillator. Okay, we'll talk about it. I don't know if we have time to talk about it next week. You can read up on it yourself. I would advise you to read up the difference between cardioversion and defibrillating a patient. There's a difference between that. If you're interested, you can read up. If you don't want to listen to more of talking about the same set of things, diuretics over and over again, next week we can start a new topic, a brand new topic like infective endocarditis will be okay too. But anyway, that's the fourth step. Last but not least, if it's bad, like really terrible, of course you recommend heart transplantation. Alongside heart transplantation, alongside that as your last step, second is your cardiac glycosides, your digoxin. Yes, positive inotropic action, it reduces your heart rates and also reduces your AV conduction, which gives you a lot of side effects. Bradycardia, AV block, and it can even transform some of your arrhythmias into VFib, into fibrillation. So that is why your glycosides, your digoxin is actually the last of the last resort. So people don't give glycosides anymore. as we did before. Yeah, so that's all for today. Any questions?
I have a question.
Mhm.
On the first line of treatment, since it's the heart failure, and then maybe in case if there's an ischemic issues on the heart, can I add aspirin, or it's not needed?
If there are signs of ischemia, yes,
Mhm.
you can add, no problem with that. It does not affect anything. You can, yeah, sure.
Okay. And it can go with any of the medication, right? Like if it's AC, ARB, or
Yeah.
okay.
But then again, you have to consider again when you give aspirin, aspirin is an NSAID, right? So it has also atherogenic effect to your GIT. So if you want to give aspirin alone, it is more recommended to give it together with your proton pump inhibitors to protect your GI tract. But the thing is that if it's adding more adding more drugs to the patient, and the patient might feel overwhelmed. So instead of giving aspirin, you can opt for clopidogrel, ticagrelor, or prasugrel.
Okay. Thank you.
Okay. Any other questions from everyone? No? Хорошо. Тогда thank you for coming to class today.
Thank you very much.
Hope everybody learned something.
We
All
did.
right. Bye-bye.
Goodbye.
Bye. Thank you.